blood sugars and maybe adjusting meds. And they're fun and energizing. We do a lot of icebreakers. We do a lot of games and activities and hands-on types of activities because that accelerated learning, remember you want to connect the head to the heart because when you do that, then behavior change takes place. Bundled care, you can see 10 more patients in a scheduled provider time, and actually the costs are pretty neutral because the time that the nurse and the provider are in that room is time that they would spend only seeing maybe 4 patients. The pharmacists, those topic experts come, they don't spend the whole 90 minutes there, they spend just a segment at time. Some of them have said, you know, I think our phone calls are decreasing because we're getting questions answered with a whole group. And so it really is pretty neutral costs. The design, initial intake is completed before they come to the group. The history physical is done. Lab works are completed. I said usually 8 to 10 is ideal. We've had as many as 15. They meet for 6 weeks. They have little goals that they do each week. They have little assignments. And it's amazing to watch how many they do. When we do the food labeling and carb counting, it is amazing to watch them come back the next week and share what they have learned on labels. Or share and say, oh my gosh, you know what, I went to Macaroni Grill. Do you guys know how many calories are in one of those plates? I mean, they become engaged. Some of them have bought smaller dishes because I don't know if you've noticed lately, has anyone bought wedding gifts lately? The plates are enormous. And so a lot of them have even bought new dishes so their plates are smaller and they're not eating such big servings. Look at serving sizes in our restaurants right now. It's ridiculous. And then if you try to share a plate, me and my husband try to share a meal, they charge you $4.50 for the extra plate. It's kind of crazy. So they have self-assessment sheets that talk about nutrition, their goals, their major problems they're facing, and where they want to go. Individual assessment, like I told you, is done by the provider and nurse within the group space. They get 5 minutes during a designated time during the 6 weeks. Facilitated by the group leader, RN with the provider. And then, like I said, there's many other ways we can take this same model. We've just successfully done it with congestive heart failure. We're getting ready to start one with hypertension with this same model. It'll only be an hour, but we'll have an education packet. The medical provider will be meeting with those 10 patients in that 1 hour and talking about hypertension, adjusting meds, because we have found it so successful. Sorry, turn my page here. Outcomes. So we do all this. What are we measuring? We're measuring their A1Cs. We have surveys. We're actually measuring the knowledge they have learned. We're measuring patient satisfaction. And a new one we want to start doing that we haven't done is staff satisfaction. We all get all those surveys every year on employee satisfaction. It has been so fun to hear staff that have been partaking in this. Even the pharmacy staff, even the PT staff, we want to start designing a survey to start measuring staff satisfaction. Ongoing benefits. Integration of shared medical appointments. You can kill 2 birds with 1 stone. Telehealth, we're starting to use it. We haven't quite gone there yet. We have July 1st scheduled to start doing an outlying clinic for telehealth. And then, as I said, adapted for many different models of chronic care such as COPD, CHF, hypertension. So here's some of our outcomes. One of the questions we ask is, I know how to treat low blood sugar. Remember, high blood sugar won't be the one that kills you. It's the low blood sugar. So we really emphasize that. The pre-class, we had 8% and 53% that either strongly agreed or agreed. And by the post-class, we were at 30 and 70. That's exciting. Those are incredible outcomes. Confident in managing my diabetes. At the beginning of the class, only 11 strongly agreed, 34 agreed, and we went up to 19% and 67%. I know what causes my blood sugar to increase. Kind of the same things from pre to post. We're seeing some pretty significant changes in patient knowledge. I know how to lower my risk of diabetes problems. Kind of the same pattern is following in our classes, pre and post. Know how to choose healthy food. Strongly agree and agree. Seeing increases in those also. And this is one I love, because this is the post-class. Remember we talked about motivational interviewing. How ready are you? How confident are you? Look at the end of our class. 71% were on the 5 scale of I am so ready to make changes and manage my care. That to me is exciting. That to me is, I love it. And then quality of the Diabetes Your Way classes. This is our patient satisfaction. As you can see, it's either excellent or good. They are loving the classes. We have people that want to re-sign up for them, and it's like, no. But you know what we want to start doing is having them come as facilitators. Start doing a little bit of training and that's another way to really involve patients in care, letting them become the expert. So we have a couple that have done phenomenally well that we are thinking about kind of integrating even that little piece into it. Are there any questions? I kind of whipped through that pretty fast. My biggest thing is that this was a grassroots effort. It wasn't mandated by the hospital. It wasn't mandated by any quality initiative. It was nurses sitting around saying, how can we make better outcomes for our patients? And that sat around cups of coffee for a long, long time, researching and developing a class. And if you don't think there's not power in nurses, there's power in nurses. And the exciting thing is that it came from a passion. We wanted to help our patients get healthier with sustainability. And it is sustaining. Over a year, A1C's dropping an average of 1.7 is phenomenal. Any questions?
First of all, I don't know if you said where you were from.
I'm from VA, Montana. I manage 3 clinics in central Montana.
Cool. And how do you charge for these then?
Well, the private sector is different, but one thing about diabetes is there's a high copayment for anything related to diabetes. Right. Anyone with a third party, there is a copay that can be garnished from it. So it actually is very cost beneficial.
Would they charge at a group rate or just like a physician's?
We do a group rate. We use codes that for group care for a provider and group care for the nursing part too. That way we capture workload credit also.
Can you spread this nationally?
I'd love to.
That sounds great. My daughter has MS, and this sounds perfect.
Oh, absolutely, yes. I would love to. Our little storyboard has gone to several VAs throughout the country being looked at. We just had somebody come from one of our places that looked at it as best practice. So, but the neat thing about this model is it's portable. It really could be implemented, private sector or the government sector, whatever. It could be implemented anywhere. Yes, sir.
I think part of it is giving them a new knowledge support group, a peer group, because like an alcoholic, they go back to the same people that
Yes.
they're going to pretty soon grab that next year.
Exactly.
But if you pick new friends and new people to run around with, you're not
Yes.
going to be as tempted.
Yes.
And I'm sure that affects food the same way.
Yes. And a lot of that's tied into motivational interviewing. What do you need to change? And some of them will say, you know, my family's whole social life is dinners and big dinners. And so it's asking the right question to draw that out to see what kind of changes they need to make. Some of them, they don't stop by the bar anymore and have a beer with their friends. And so you're exactly right. Excellent point.
I was
Yes.
just wondering if you've ever tried anything like this for juvenile diabetics. I know that there are a lot of juvenile diabetics in our area, and I just think that that would be something that would be interesting for them, and maybe they could learn a lot through a peer group.
She asked if there was anything like this for juvenile diabetics, and you are right, and that is increasing at an alarming rate. I see no reason why this type of model could not be incorporated into that. All of our 6-week classes are very evidence-based. They were all based on research, so it's not just namby-wamby. It's very solid teaching and education that is done. But I think it's very portable. I think it could even be used with women's groups, HIV groups. It's just, I think it's endless of chronic care that this model could be adopted for. Yes.
Do you try to separate your patients insofar as initial diagnosis or follow-up for those that are on insulin or pipeline or insulin pumps? Do you
That's a good question. And we're looking at that down the road, but what we're really focusing on right now is anyone with an A1C over 9. However, we're integrating new diabetics into the classes too. We have women and men combined because we're learning if we can get that new diabetic in there too, they may never get to a 9. And that's what we want. We want them in that 7 range. So good question. They're integrated. Gender, age, and where they are on their journey of diabetes. Anyone else?
So after a year, you know, you said that you're there 6 weeks, then 3 months, 6 months, 9 months, a year. What about long term? I mean, do you have a plan set up for after that 1-year period? Or did I
Yes. They will. Our physician champion at this point is not their primary care doctor. The new classes we're leading will be their primary care doc. But yes, they're followed up with their primary care doctor, and the champion and the primary care doctor work very closely together. What's great about it is the primary care doctor doesn't get offended if she makes changes in their medications, because it's that whole concept of team. What's best for the patient, that patient-centered medical home model that we're all moving toward. So there's no egos in the way. It's just really what's best for the patient. And then their primary care continues to follow them up. And our diabetics usually come in about every 6 months or sooner. But the neat thing about this is now they know when to call, because they know if my sugars are out, something's wrong. If I'm running low too much, I might need my meds adjusted. If I can't get my sugars under control, I might be coming down with something. They're educated enough to know when to direct their care. We're not so much directing them anymore. You know, we tell people to come in every 3 and 6 months, and sometimes they don't need to come in every 3 to 6 months. We're starting to also use telephone clinics to where we actually call patients. And so follow-up telephone calls. Hey, John, how you doing? You finished the class last year. It's been 3 months. How you doing? Are you still succeeding? What's going right? What's going wrong? Those motivational interviewing questions. So it's kind of been our pilot in the last year, and we've been just so excited over the outcomes that want to start spreading it out to the rest of our clinics. Anyone else?
Do you have cards?
I did not bring them with me. I didn't do that. Deb Charlton at VA Montana Healthcare, you can get a hold of me. Anyone else? Just goes to show somebody with a passion can make a difference. So keep those fires burning, because if there's anyone that has a passion, it's nurses. Thank you. What an honor to be here.